Welcome. My name is Janet Gripshover. I'm a nurse practitioner by training and the nurse manager for the liver transplant department at Cedars-Sinai. And I know that we may give another minute or so to see if anybody else joins, but I didn't know if anybody had any pressing questions or anything they um, wanted to get off their chest, or if not, you can also drop it in the chat and we will certainly get to that because I understand how uncomfortable it can be sometimes speaking on a Zoom call like this. But anyways, I'm really glad that you guys joined, and yeah, just give it another minute or so. Like I said, my name is Janet Gripshover. And I've been doing liver disease for a very long time, and I love getting questions and getting off topic, and it's very easy for me to do so. So feel free to give it your best shot. And also don't forget to register for the meeting. For credit. Okay. All right. And with that, I know we are recording too. So if there's any content or information that you are looking forward to or want to review, then please remember that you'll be able to access this information later. And with that, let's go ahead and dive in to talk about MASLD and MetALD, which is MASLD is the newer nomenclature for metabolic associated steatotic liver disease. So MASLD, it replaces the old name, which was NAFLD, which is non-alcohol related fatty liver disease. The name was changed a couple of years ago to reflect basically the larger components that contribute to this basically non-alcohol related fatty liver disease. And then a new diagnosis was generated basically with that to acknowledge that there are patients who have metabolic risk factors, but also have a robust enough alcohol history that it's really hard to determine how much of it's metabolic associated versus alcohol associated steatohepatitic or steatotic liver disease. And so MetALD was created to help categorize and understand that there are patients that have a little bit of both. All right. And with that, let's go ahead and get started with the case study. So Ashley is a 52-year-old woman that has been referred for evaluation after having an ultrasound done that showed mild hepatomegaly and increased hepatic echogenicity consistent with steatosis. She feels well without complaints. She's 52. You can see that she's white, female, and her BMI of 29.4. Just as a reminder, obesity is classified as stage 1 at 30. So you can see she is just under that and technically qualifies as just being overweight. This is a very, very common patient presentation for patients in the outpatient world. A lot of times people will get an ultrasound because of maybe some vague abdominal pain. Primary care will get it, or sometimes even for screening purposes. She fits a lot of the characteristics that we typically see for ruling out gallbladder disease, so it might have even been done for that. And ultrasound technology is so good these days that we can tell so much. And so it's very common now that what we'll see on an ultrasound is that the texture of the liver isn't very smooth. We'll see that it's got a lot of variability. And it will often read as a different texture than the spleen, which is sometimes how they can tell whether there's increased fat in the liver or not. So again, this is very common presentation for patients who have increased fat in the liver. All right, so she comes in, and because we are fantastic healthcare providers, we go ahead and get a great medical history. We see that she has a history of polycystic ovarian syndrome, hypertension, and hyperlipidemia. And social history is that she averages about 2 glasses of wine per day. We see that her medicines, she takes medicines for blood pressure and cholesterol, which is consistent with her medical history. She also takes a multivitamin and milk thistle, which when I was reading this, I thought was a little bit interesting because it makes me think that she's aware of her liver disease. This is not maybe the first time that she was told about something going on with her liver. So that puts a little bit of a red flag in my mind. Okay, how much does she know about what's going on already? But really, already here, you already have some elements of a potential diagnosis. We have right here three different, or really four different risk factors for cardiometabolic risk factors. So patients with polycystic ovarian syndrome are at a much increased risk for getting just metabolic disorders. Hypertension, again, another risk factor with hyperlipidemia, especially. Again, we know that those are all contributing to cardiometabolic risk, and also with that elevated BMI. But we can't call this straight MASLD because she does have a significant alcohol history here with 2 glasses of wine a day. I will talk a little bit more about what that actually means because that's what patients will say. They say, I drink 2 glasses of wine a day. And I don't know about you, but I don't know the last time I actually measured a glass of wine. It was probably over 10 years ago because I was just curious to see exactly how much was in one of my own pours. I find it personally a lot more rewarding when you ask about an alcohol history is to ask, okay, what is your drink of choice and when was the last time that you had anything to drink? And again, she said wine. You ask when the last time was. And then you ask, especially if it's something that you don't measure, you say, well, how do you buy your wine or how do you buy it? Because that's the way it's measured. And you can say, well, I get a bottle, I go through a bottle every other day. Well, that tells me that, that's about, again, a bottle is usually around 4.5 servings. So you're having a little bit over 2 servings if you go through a half a bottle of wine. Oftentimes with wine drinkers, though, they're also they typically buy their wine out of a box. So you can ask if it's the 3-liter box or the 5-liter box, and how often do you go through it? Okay. On physical exam, also not surprising, is that her liver edge is smooth, non-tender, and again, basically a normal physical exam. From here, we can take a look, and now we've got our vital signs. So again, based off that last presentation, we know that whatever's going on with her liver, that increased fat in her liver is she's got cardiometabolic risk factors, and she does have a significant alcohol history. So we know already that MetALD is high on our list, and what we want to figure out is how severe that it is. So we can get that for some of the other information here. We've got a blood pressure that's a little bit on the high side, again, consistent with her history of hypertension. That is not a respiratory rate. That looks like a pulse to me. Sorry, I just caught that. We've got again, normal temperature, height and weight. Again, she's short, but she's also got that BMI that's a little bit elevated and consistent with being overweight. Her transaminases are a little bit on the plus side. Again, a little bit consistent because you saw that she was taking milk thistle, which is a herb that has been purported to help with liver health. It's not, unfortunately, doesn't have to seem a lot of efficacy, but a lot of people still believe in its use. It doesn't hurt. I usually don't tell people to do anything with it when I see this kind of presentation because, if it makes them feel better to do it and they sleep better at night, then that's, no skin off my back if it makes them feel better. But hasn't really been shown to work to improve anything. So you see she's got mildly elevated transaminases. I'm a little bit concerned that her AST is mildly higher than her ALT. Because we see that flip happen in 2 different disease states. One is cirrhosis. You can get that where a cirrhotic liver can't make that ALT very much. But we also see that kind of flip where the AST is higher than the ALT when there is usually alcohol on board, because alcohol suppresses the liver's ability to make ALT. So again, it's one of those things that just a little nugget for later in the back of your head is like, okay, so what is that? Is that because her alcohol use might be a little bit higher than what she actually admitted to, or is there could be possibly like maybe an early cirrhosis going on where the liver is just having a hard time making that ALT. Her ALK phos is within normal range. She's got a mildly elevated T-bili, which again is a little concerning. Again, when you see that flip, it makes me wonder, okay, what's the liver? This is not normal. The liver is not behaving normally. What's going on here? Good signs, though, protective factors, is that her platelets are robust. So that's leaning towards having less chances of having any portal hypertension. We typically see, again, a low normal platelet count of around 150. Anything below 150 sends up warning flags in my brain that cirrhosis might be on board. And then going on with the cardiometabolic risk factors, we have an A1C that's just below the diagnostic cutoff at a 5.9. So that's a sign of some insulin resistance, and her triglycerides, again, not that bad, but not normal either, especially if she's on some lipid lowering agents. So again, very consistent with a very, very typical. This is very typical presentation for what we see when we have patients that are referred to us with basically a wacky ultrasound, is that you get this mixed picture and you just got to figure out what's the driving factor here and what are we treating. All right. So we are very lucky. We work in a clinic that has a FibroScan machine, and so we grab one of those. Now, FibroScan machines are wonderful. What it is, it's transient elastography. So what it is it's sending a sound wave through the liver, and it's measuring how hard and fast it bounces back. And from that, we can get an estimate of how much fibrosis or scar tissue is within the liver. Now, one thing I'd really like to point out is that, and we see on her, I'm sorry, before I do that, we see that her FibroScan stiffness score is 11.4 kilopascals. Now, one thing I'd like to point out is that the FibroScan ranges that have been published vary a little bit based off of the etiology. We know that patients with alcohol-related liver disease tend to have slightly stiffer livers, and that's likely due to the inflammatory effects of alcohol. Alcohol causes the liver to get inflamed. Inflammation makes it a little stiffer, and so the ranges are a little bit wider. So for alcohol-related liver disease, an F3 would be somewhere between like 11 to 19 kilopascals versus just straight fatty liver or metabolic associated fatty liver disease with a range between 8 to 14. So you can see it's a little bit on the lower side. Either way, she's qualifying for an F3. So this is somebody who is certainly, based off of our testing today, at risk for developing cirrhosis and further complications of liver disease. Also, what's fantastic about having a FibroScan report is that we can get a CAP score of which basically gives us a sense of how much fat is in the liver. And at 310, we've got pretty significant fat reading in the liver. So we know that her liver's sick. We need to do something to get the fat out. It's on its way to becoming cirrhosis. And the thing I usually tell patients with cirrhosis is all cirrhosis means is that you're at risk for getting other problems. It doesn't mean that your liver's not working or that you're going to go into liver failure, but it means that we need to make some changes so that we can prevent that from getting any worse. This patient is right at the cusp of that and is at risk for going down that road. So we need to do something. We need to make some interventions now to help prevent that. So with all of this information that we have, one of the things that we would this is a idea to think about when we think about this steatotic liver disease umbrella. Think of it now as more of a spectrum of disease. So we have on one end the patients who have more pure metabolic associated liver disease or metabolic associated steatotic liver disease, basically fat in the liver from these cardiometabolic risk factors. And on the other end of the spectrum, we have the alcohol-related associated fatty liver disease, because that's how alcohol damages the liver. It causes the liver to hang on to more fat. And then in between, again, we've got this range of how much alcohol is influencing the amount of fat in the liver. So, people who might drink moderately, but maybe not to the point of really a alcohol dominant picture, versus patients who are maybe light drinkers, but they have a lot of cardiometabolic risk factors, and that can still cause enough damage and enough liver injury or insult to cause furthering disease. The really only difference, and the way to tell this is basically by getting a really good alcohol history. So that is one thing that when I've precepted other nurses or talked about this, if I can encourage you to do one thing, it is to really get learn how to take a good alcohol history and try to elicit real responses from patients. I also don't want to ignore the fact that there are other etiologies that can cause steatotic liver disease, including drug-induced liver injury. I will say methotrexate is a very common medicine that can cause this. There are also some genetic disorders that can cause increased levels of fat in the liver, and sometimes we also just don't know exactly how it happened. There may be no cardiometabolic risk factors involved, and people can get more fat in the liver. This is still a growing field of why do people get fat in their livers, and what do we do about it? So just throwing that out there. All right, so alcohol. I love this slide. Please remember this slide. Take a screenshot of it, because what I love about this slide is, one, it shows you that the only thing that's measured on here is that can of beer. That is the only thing that you can really rely on. Patients will say, I drink 18 beers a day. We just had that patient come in the other day. And we know exactly how much that they're taking. And yes, that is an alcohol-related liver disease. But remember that, malt liquor typically comes in either a 20 or a 40, and it's a little bit of a higher proof. So you get increased levels of alcohol with smaller amounts. Red wine versus fortified wine. Again, people don't usually binge drink fortified wine, but if somebody likes their port after dinner most nights of the week, then you can ask how often you're buying that bottle. They usually come again in a 750 ml, which is also known as a fifth. And again, how often do you go through it? How often are you buying it? Same thing with spirits. What size bottle are you what size bottle are you drinking, and how often do you have to buy that? It gives you a better idea of how much they're actually consuming, because patients will often say, well, I only have like 1 or 2 drinks a night. And then you find out that they're like a drink is actually an 8-ounce glass with a little bit of ice in it. And again, it's not really, you have to look at their servings. All of these amounts that are shown here are equivalent to 14 grams of ethanol. And I point that out because when we talk about how much alcohol do you really need to cause liver injury, it gets really important when we talk about that. So again, 1 serving is considered 14 grams in the United States. I'll also say in other countries, I want to say Canada, a serving is considered, I think, 13.5 or 13. I don't remember off the top of my head. And Europe is the same way. It's a little bit lower, is considered a serving. Us Americans, we like it big and in your face. So 14 is considered a serving here. All right. So key pathogenic mechanisms in this dual etiology, this MetALD. On this slide, you see it using the older nomenclature, and a little bit for that is because when a lot of these studies were being done on fatty liver disease, we were still using that older nomenclature. It wasn't until very recently, I want to say in 2023, probably right around the time that this article was published, is that the nomenclature changed. But again, we see all the different risk factors with insulin resistance, all of the ones that you learned about in school, all of the things that we know that we need to do better in our own lives, including alcohol intake, can increase basically the load that goes into the fat on the liver. And then alcohol and even fatty liver disease or bad diet can also cause some intrinsic issues where you get this altered microbiome, you get increased production of the lipopolysaccharides, possibly even fermentation and ethanol production in the gut when you have some of these issues, and that can make things happen faster and worse for the liver. There is so much work being done right now on gut microbiomes and its influence. In my personal experience, I shouldn't say my professional experience, not my personal experience, so to speak, but patients who have had alcohol related liver disease, when they finally stop, one of the things that I've observed is that they get this really intense abdominal pain, almost like a SIBO type, or what is it? Small intestine bacterial overgrowth type syndrome, where it's just crampy and it's just really uncomfortable. And I am convinced that there's probably some sort of altered gut microbiome going on just from their chronic alcohol use. It's just going to take some time to get over. I would love somebody to prove me right on that. I don't have the time, inclination, or the research funding to do that, but it's something that I've just observed with a lot of patients that come in who have a history of significant alcohol use. In addition, again, when you have this fat and this inflammatory response to the fat, you get this chemokine upregulation, this macrophage activation, and immune system. When you get a biopsy, you can really see this this almost lymphocytic party that happens that causes this inflammation. And I'll say that's the difference in the diagnosis between MASLD, which is your metabolic associated steatotic liver disease, versus your MASH, which is your metabolic associated steatohepatitis. The hepatitis being the one that's associated with the increased inflammation. And that inflammation, we think, is what really gets this disease going into high gear, and the likely thing that's going to push patients into getting down that fibrosis pathway. All right. So drivers of liver disease again. So again, thinking about the spectrum of fatty liver disease, you've got the MASLD on one side and the alcohol-related liver disease on the other side. Again, risk factors that can increase that risk. And then alcohol use, as it increases the use, the likelihood of it being more alcohol-dominant liver disease increases, obviously. And remember what I said about how one serving is around 14 grams of alcohol? If you see that, you can see that 20 to 50 grams, again, that's per day of alcohol use, is associated with increased risk of liver disease. And you can see that that's really like a drink and a third for women. So, I think that 2 drinks a day pretty solidly lands our patient into that mid-MetALD range. And you can see for males, it's a little bit higher. And the reason for that is because men tend to be a little bit bigger and their livers tend to be a little bit bigger. And so their livers can handle more alcohol than women can, just on average. So especially on a 5'2" woman, I'd imagine that her capacity for metabolizing alcohol is probably going to be a little bit reduced compared to, say, a 5'8" woman. All right. And we can see here too with the fibrosis stage that she's got, her kilopascal was around 11. So she's somewhere like right around in this range, in that F2 plus range. And we can see that her 5-year risk for decompensation, which is basically permanent effects of liver failure, is around 10 to 30%. So we need to do something about this. We need to put her back on the right path and, avert any further liver damage as best we can. So we ask her, we say, hey, can you please cut down on your alcohol or really stop? We don't want you to drink anymore. Your liver's pretty much done with it. You've got these other products of aging like this PCOS and obesity, and we want you to lose weight and stop drinking. And she comes back in 3 months and she says, yeah, I totally stopped. Well, there's a couple of different ways that we can detect and trust but verify. So again, we can give her a questionnaire. We can also do some other tests. We can do an audit C to see if she's got alcohol use disorder. We can also test of these blood tests. The GGT was kind of a quick and dirty for liver inflammation, which I'm going to tell you right now is going to come back positive just because she had some elevated liver enzymes. So almost certainly that's going to come up. A urine ethylglucuronide is another test that will measure for alcohol use within the past week or so. And also there's a hair test, but I don't think I know anybody that has gotten one of those. Again, we can look at her diet or we can look at her other past history with the fact that she is overweight, that she has not very well controlled hypertriglycerides. Again, she's got a little bit of insulin resistance. So again, she does have some metabolic risk factors doing that. So if you do decide to get a ethylglucuronide, and again, when we see this, we know that, or when we really test and when we really look at it, that patients who have historically had what we thought was metabolic fatty liver disease, we know that a good proportion of them do have some alcohol use and an alcohol use in their history. So even if they are not admitting it, what we can do is to try to identify other ways that again, even if they're not admitting it, or they're not telling you, or they're not being as truthful with you, we can identify other ways that people are consuming alcohol. And of course, screening for alcohol use disorder with an audit C. All right. All right. So going back, when we talk about this, it can be probably figuring out where on the spectrum or what is going to give you the most bang for buck as far as recommendations to a patient that has this mixed etiology disease, is that we have to really figure out, if because the patient's only going to remember 10% of what you say. We really have to figure out what is the thing that we really have to address and encourage the patient to do to help head off this disease state. So when you have a patient that has a very, the similar kind of presentation to our patient here, yes, we're going to be talking about all of the controllable things. She admitted that her diet isn't fantastic. We saw evidence of that on her blood tests, with the A1C being a little bit on the plus side, her triglycerides being a little bit on the plus side. She also has some pretty significant alcohol use. I would ask her, um, what are the reasons that you drink? Like what are some of the things? Do you just like it? What are the things that we can do to help get you to stop? Because again, this is a mixed media, or this is a mixed picture of disease. And she's at risk for further decompensation. And we know that again, if she doesn't make some changes, she's going to be in your clinic within the next 5 years with some sort of liver failure problem. So we need to get on this now. What I would recommend, as far as again, this is a really great way of thinking about how to kind of identify and which side and figuring out which treatment, because obviously if this is a metabolic dysfunction, we've got other treatments for that versus alcohol use, which the treatment is basically don't drink. And there are different medicines that we can use to help treat both of these etiologies. The devil is in the details of figuring out, again, which side and which treatments that you need. Ideally, the recommendation for this patient is probably going to be to do both, right? We want to get her to stop drinking. We want to get her to take care of her body a little bit more. And again, with our patient too, she did have, if she didn't have the other risk factors, if she didn't have the polycystic ovarian syndrome, if she didn't have, uh, if she only had either the hypertension or the hypertriglyceridemia, then we might want to consider, if she didn't disclose to us her alcohol use, we might want to consider testing just to see if she is not being forthcoming with that information. The PEth test is a common test that is being used a little bit more frequently now to identify alcohol use in patients who may not be forthcoming with the test. What it is, it's a blood biomarker of alcohol use within the past about 3 months. It is a direct metabolite of alcohol, and it is only really detectable in patients who have significant previous alcohol use, or like either like daily routine, again, like our patient who has like 2 drinks a day, versus like a good binger, like maybe like a binge drinking episode, which for a female would be approximately 4 to 5 drinks in a sitting, or in a couple hour sitting, one time within the past 3 weeks, is enough to cause a positive PEth. And again, we can take a little bit of a estimate if our patient wasn't forthcoming with how much she's drinking, or if we want to verify how much she's drinking with a PEth test. There is a minor correlation into the level of the PEth test and how much alcohol that they are actually consuming. I will say that this isn't 100%. There have been reported cases of patients who have discordant alcohol history and PEth test on basically in clinical trials and in clinical studies, is really uncommon. Generally speaking, for 95% of the patients that walking through, there is a correlation, and there is also intra-patient correlation. So let's just say we check a PEth on our patient today who admits to drinking twice a week, and we get a PEth that comes back of around 40. Let's say we tell her to stop, and she comes back in a month, and we repeat that PEth test, and it comes back as 200. We know she absolutely didn't stop. This isn't a possible false positive. She probably increased when we told her to cut down. So again, when you have possibly either like one or two cardiometabolic risk factors or significant alcohol use and you're not really sure, that's another thing to consider your PEth testing to figure out which side of the fence that you might be on. Okay. Again, talking a little bit more about our PEth, we do a PEth test on our patient. She comes back at 120, which is a fairly robust thing. I would say based on her history, when she said she had 2 glasses of wine a week, that this is probably she might be underestimating a little bit what she takes. This is the patient that probably, again, I would have recommended asking instead of how much are you drinking, I would say, how often do you buy your alcohol and what size do you buy? Because that's the last time that it's actually measured before it goes into their body. And again, coming up with an estimate based off of that. But again, you can see that a positive PEth usually is anything below a 20, and you can see that it's usually very low alcohol consumption. That would be maybe one drink once a week would come up with a PEth less than 20, just to give you guys a ballpark of what that would actually look like. Okay. So again, diving a little bit more into the phosphatidyldiethanol testing, you can see there is a correlation to when that basically how much that you are how much PEth that you're making versus what your blood alcohol content is. This is measured over hours. And again, after one single binge, again, you can see that it does tend to go up. And again, this PEth level can persist for up to about 3 weeks afterwards, give or take. And it'll start to slowly trend down over the next few weeks after this. And you can also see that there is a correlation. It's not 100%, but there is, like I said, intrapersonal consistency that you can have a patient who has low basically lower alcohol use, but come up with a fairly significant PEth. You can see these outliers here, so it's not 100%, but again, is really good for intrapersonal variability. Again, it's really good for trending alcohol use. All right. So in patients that again, looking at patients who are overweight and looking at their alcohol use patterns, what we found is that there was a study that was done of a little over 600 patients that were screened for the study, with most of them enrolled, and about half of them we had that admitted to also drinking alcohol at the same time. And what they found was that in women, there was an estimate of about 140 to 350 grams per week, with a PEth greater than 25 nanograms per milliliter on testing. And what we found out with these patients, again, was that these are patients who likely had a metabolic related liver disease, again, because they had the significant alcohol use. And again, it was a way that we were able to try to figure out to stratify fibrosis and what their risk factors were for developing further liver injury and further disease. And we found that of these patients that had suspected metabolic and alcohol-related liver disease, that 15.7% were at risk. All right, so we go back to our patient. Like I said, she's got these risk factors for metabolic-related fatty liver disease. And we know that she does have this increased average of of 2 glasses of wine per day. So again, it's likely that she also has this condition. But what are we going to do about it? Well, with this patient, I would probably recommend that she does both, that she loses weight and that she cuts down on her alcohol use, including, and again, we know that alcohol is going to increase her risk of hypertension. There's a good chance that if she stops drinking, that she'll actually may even be able to come off of some of her high blood pressure medicines. We know that alcohol can decrease the blood pressure up to 12 hours after consumption, but over time, it will cause that swing back where it goes up again. And patients who have chronically consume alcohol do tend to have hypertension. We also know that alcohol causes increased triglyceridemia, where again we can see that over time, patients who drink regularly tend to have higher triglycerides compared to water. So going back to our patient here, again, just going over a little bit, we see that she's got, these are her labs. We've got a little review on her meds. On her exam, looks pretty normal. She's got this really concerning history here, and hopefully you're going to take most of your time to do some basically lifestyle coaching with our patient so that we can try to improve these numbers a little bit. So again, I think I've talked about this. She's got MASLD, predominant met alcohol use disorder, because again, while she does drink fairly robustly, she does have a few more risk factors for fatty liver disease or for metabolic associated fatty liver disease. All right, so what are we going to tell her to do? We're going to tell her that she needs to change her diet. Mediterranean diet has been shown to help decrease MASH risk in patients with MASH, and basically fibrosis risk in patients with MASH. We're going to encourage her to exercise. This I cannot underline enough. Increasing muscle strength and basically activating your muscles and stimulating your muscles is one of the #1 things that especially women patients are not apt to do and can give you the biggest bang for buck. Not only does it increase your insulin sensitivity, but it also increases your metabolic rate. It prevents frailty as you get older, and it can also encourage weight loss because, again, increasing that metabolic rate. So I would absolutely focus on that. This patient is also a candidate for resmetirom, which is one of the first treatments that we have for metabolic associated fatty liver disease. It's indicated for patients who have at least some fibrosis and are on that pathway towards cirrhosis, and it can help decrease the amount of fat in the liver and reverse fibrosis as well. So this is a patient that you may want to consider doing that. As far as alcohol use goes, I don't think that I have to say it again, but you need to tell her to stop. I would also recommend, as somebody who works in a transplant center, that you don't mince words and make sure it's very clearly documented that you told her that she needs to stop 100%. I've seen a lot of community GIs that I think get very hesitant to recommend fully stopping because they don't want to upset their patients. They don't want to scare them off. They don't want to come off as non-negotiating. But really, when it comes down to it, if this patient doesn't stop, she is likely going to continue this use. She can do all the diet changing, exercising in the world, but alcohol is not doing her any favors, and so she absolutely needs to stop. Not to mention 2 glasses of wine a day is an extra, what, 300 some odd calories plus, because she's probably underestimating. If she just cuts out the wine, she could probably drop a pound a week. So again, it's another thing to help just reiterate on the importance of stopping alcohol use. And does she need HCC screening? And I think that this is a really interesting question, because we know that patients with fatty liver disease, which again, I keep on saying, but it's MASH, with at least a stage 3 fibrosis are at an increased risk and are recommended to get HCC screening. Whether it's, generally speaking, I'll say ultrasounds are covered. More invasive tests like MRIs, typically you do need to cross into that F4 category to get that covered. And even then still sometimes it's not covered, but Q6 months ultrasounds plus AFP is considered adequate for HCC screening. And I would absolutely recommend that you consider doing that for this patient. So again, the ideal MetALD definition that we've been using for clinical trials is basically we try to use as many biomarkers as possible just to help standardize, because alcohol use is oftentimes done by history. so we really need some more objective measures and also to help us standardize the assessment. We also want to ensure that drivers of liver disease are present, including cardiometabolic risk factors. And we want to make sure that, again, because we know that alcohol can cause hyperlipidemia and hypertension, we want to, kind of try to carve that out. And if they have that without the alcohol, then that is also, again, a cardiometabolic risk factor. And then other exposure to just other risk factors. We want to see that they've had, fulfillment of the criteria for either one of these during the past 6 to 12 months. Okay, so take home messages. We really want to make sure that when you're looking at trying to distinguish between MASH and MetALD, you need to really consider if there's more than one cardiometabolic risk factor, or you need to make sure that the alcohol use is significant enough to also be causing some injury with that. And again, this new definition is that you've got this alcohol intake between 140 to 350 grams or 210 to 420 grams per week for women and men, respectively. And again, that usually boils down to women to somewhere about 2 to 3 drinks a day for women and around 3 to 4 drinks a day for men. Again, that's rough estimates. Don't take that to the bank. But just to give you an idea of what kind of amounts that you're looking at. Remember that your clinical criteria could underestimate MetALD, so you might want to consider using your alcohol biomarkers, or again, like I said, try to talk with your patients. What do you drink? How often do you buy it? That is such an important part of getting this alcohol history. And the last thing I'll also say on this is that you also have to know a little bit of your local slang, because especially if you're talking with somebody who, they're not going to say like, oh, I drink 750 milliliters of wine every night. They might say a large bottle. Or I used to work in Baltimore City, and one of the things that I remember a patient saying is like, well, I drink a shorty and a beer every day. So what's a shorty? Well, I had to find out. It's actually I want to say it's like a quarter bottle. It had about 4 shots of alcohol in it, which is obviously enough to cause an alcohol-related liver disease. But it was one of these things that you just kind of have to know. Go to your corner liquor store, see what patients are buying. Another thing too, a lot of times people who drink malt liquor will often say that they drink beer, and it's not beer, as we saw in the other slide. It's a higher percentage. It's often sold in larger amounts. I had one patient, it was documented all over his chart. I drink 2 beers a day, male patient. You don't think, hey, that's probably, that's not that abnormal. It's on the plus side, but it's not considered heavy drinking. I asked him to what? And it turned out he was drinking 20-ounce cans of a malt liquor. And he used the brand. He's like, well, it's 2 Natty Daddies, which in Northeast Pennsylvania is a local brand of malt liquor. And I was just like, oh my God, like this is actually like 4 to 5 beers a day. So of course I corrected the documentation on that. Unfortunately for that gentleman, it was a little bit too late. He had already developed cirrhosis, but it was one of these things nobody thought to ask more about it. So it was a diagnosis that was missed for years, and the intervention was not caught in time. You can also, again, consider getting a PEth test, again, to trust but verify what you're getting. And again, you want to make sure that you reassess your metabolic dysfunction over time. Let's say our patient here that we were talking about, did the diet. Maybe she did stop drinking. Well, if she stopped drinking and she lost weight and started taking care of herself, maybe those metabolic risk factors will be going away. So again, just trying to reassess that. Or maybe they got worse. She does have PCOS. Maybe she'll gain weight and that cardiometabolic risk factor will get even worse over time. All right. And then consider if she's had adequate exposure to risk factors. Maybe she just started drinking 2 drinks a week. Recently, maybe she had a breakup or something like that, and that was a new onset thing. So maybe this is more of a MetALD. Yes, you're going to still tell them to stop drinking, but again, that may not be the most significant driver of disease. And again, clinical criteria when we do clinical research, again, usually we're looking at trying to standardize this to try to allow for comparisons. So I'm just throwing it out there as a thing that we do tend to look at, and in the real world, it may not apply 100%, but it's something to consider. So with that, Please be sure to visit the GAP MASLD MASH Community Network for additional disease state education and education on Rezdiffra. And feel free to take a short survey to share your thoughts on my presentation today, and I hope that you guys enjoyed it. And I'm also free to take any questions if you have any.